Hello and welcome. I hope you can all hear and see me. My name is Sam Smith. I'm from Enovis. So thank you so much for joining us this evening for what is an extremely relevant topic. I'm confident it'll be insightful and hope that it will give a positive influence for your practice and your patients too. Slight technical one there, but yeah, firstly, a quick intro for those who were not familiar with who we are. So formerly DJO, we're a global medical technology company providing clinicians and patients with leading products to provide exceptional treatment outcomes. And we are absolutely passionate about getting patients back to the activities that they love. You may well be familiar with a number of our brands, including our braces and walker boots from the likes of Donjoy and Aircast, through to our Chattanooga brand, which specializes in modalities such as shockwave therapy, muscle stimulation, and our brand new Light Force therapy too. Of course, if you have any questions or product-related queries, we'll be able to provide our contact details off the back of this webinar, which we'll put in the chat. So next, a quick intro into the speakers today. So as I said, my name is Sam Smith. I'm the marketing manager for Enovis UK and Ireland. We'll also be joined by Craig Wilson, who is our clinical product specialist here at Enovis and also a physio, and he will be moderating the clinical discussion and Q&A session at the end of the presentation. Also welcoming Jimmy Reynolds, who is our main speaker tonight. So we're very excited to have Jimmy. He's going to bring a wealth of experience and knowledge to this, as I said, extremely relevant topic. So welcome, Jimmy. And finally, a addition to the lineup. We're excited to be joined by consultant knee surgeon Mark Bowditch, who again will join the clinical discussion later on. So finally, before I hand over to Jimmy, just some housekeeping. You will have, of course, have the opportunity to ask questions throughout today. So please use the chat function. If you're not familiar with Teams, it should be at the top of your screen there. So just pop any questions in the chat and that will allow the team to see it and they will answer accordingly. Equally, we will answer any questions that are asked towards the end of the clinical discussion, where there will also be the opportunity for us to unmute you as well and allow you to have a chat with the team. So with that, I'm going to hand over to Jimmy. So Jimmy, if you'd like to share your screen and unmute, and I'll give you the thumbs up once I can hear and see your screen.
Right, let me just remove a couple of bits. Can't seem to see my screen anymore.
Yeah, we can hear you.
Can you hear me now? Yeah.
Yeah, we can hear you great.
1 second. I just can't see my PowerPoint anymore. 1 second.
If you can just hit share for us.
Can you see my screen?
Yeah, we can. And we can hear you as well. So over to you, Jimmy. Again, thanks so much for joining us. We're delighted to have you. So yeah, after you.
Thank you very much. I very much appreciate the opportunity to have a good discussion with you all, and hopefully it will be an insightful discussion on an extremely relevant topic. And I hope it really opens the door wider on what we're doing in female ACL rehabilitation, really. A very quick statistic and quite startling, really, from a rehabilitation point of view, is that 1 in 4 females won't return after their ACL injury. And that's 25% in essence is such a huge number. So the big question that we have to ask is, are we doing enough currently with female ACL injuries? Are we looking at what we're doing with our treatment modalities? Are we looking at our rehabilitation environments? Are we looking at the sports that they're playing? Are we looking at the environments that they're playing those sports within enough to really make a big influence for these girls coming back through quite a long rehabilitation period? So I hope this will be quite an insightful discussion, and it's going to be a bit of a whistle-stop tour on a number of different aspects, but one of the key things is that I want to really draw our attention to what we can do within our rehabilitation and really what we need to be focusing on for the female ACL injured athlete. So a little bit about me. So my name's Jimmy. I work as a sports physiotherapist, and really I would classify myself as a rehabilitation physiotherapist. I really enjoy the complexities, and I'm quite passionate about about rehabilitation, really. I like to get down into the nitty-gritty of it, and ACL rehabilitation is somewhere that I can lay my hands on quite happily, and really I've had quite a lot of experience in that world. I've been quite fortunate over a number of years to work with a lot of top surgeons, and had the opportunity to work through quite a lot of complex cases that ultimately require a result. And in the elite sports setting, that can be quite an attractive thing for a physiotherapist in the sense that we have to find the solution for these athletes. And this is the expectation in elite sports, and it's a challenge that I've always particularly enjoyed. I moved out of professional sports 2 years ago, and myself and my wife, who's also a physiotherapist, we opened up Alpha Physiotherapy, which is a physiotherapy practice based in Ipswich. And really what we did is we took the viewpoint of finding the way forwards in the private setting, and it's something that we wanted to push into our business, Alpha Physiotherapy. So it's been a really nice transition for me to be able to move from a professional sports environment into a private setting, and this is where our worlds with Enovis have collided. And we are originally we were a fitting centre for DonJoy, and we've expanded on our partnership with Enovis, and we've got a lovely link with them. We utilise some of their electrotherapy equipment, as well as using a lot of their bracing products as well. So overall, I feel quite privileged. I've had a lot of experience in a number of different sports, and really my focus in the female world of rehabilitation significantly increased in the last 6 or 7 years. My role within professional football was to focus predominantly initially on the development of male footballers. And so we developed a program at Ipswich Town Football Club, for example, which was extremely successful and had very low injury rates. And we were asked by the FA to set up a centre for the girls' game within the east of England. And in the east of England, there's quite a distance between a lot of football clubs. If you know where Ipswich is, we are right on the east coast of East Anglia. And really, to get anywhere from Ipswich, it takes a couple of hours. So it's always a bit of a journey. So we were asked by the FA to set up a regional academy for the girls. And I thought to myself at the time, this no problem. We can do this. We can lift exactly what we've done with the boys, and we can put it straight into the girls' program. And I realised very quickly that this just wasn't the case. There were so many other areas that we had to start to consider. And I always remember one of the biggest factors that really started to shine a light on female sport for me was I had to use sports psychologists more than I'd ever used a sports psychologist before. We were asking girls to come into an environment that was extremely professional and extremely hard and extremely pressured. And we started to soon realize that for the female athlete and for the female football player, there was a lot for us to learn and a lot for me to learn. And it taught me a hell of a lot. So hopefully I can share with you some of my thoughts kind of through that. But also, as we've continued with Alpha Physiotherapy, we now see actually probably more female athletes than we do male athletes. And that's probably a sign of the professional side of female sport at the moment. They are still reaching out to the private organisations to find the help, whereas perhaps the professional organisations are still quite slow to build the staffing structures. So what I really want to talk about today is really understand kind of the current status of the female ACL injuries and why we need to focus on it. Have a little chat about our risk factors and how we can inform them in our rehab. Mention and discuss the environmental and social and the gender motor control gap, which is something that's quite relevant at the moment. But then also take us through some of the key areas in the rehabilitation. And I've got a few videos at the end that hopefully will play quite nicely over the teams that will is an example of what I'm talking about. So predominantly when we talk about female ACL injuries, the predominance is on non-contact really. And we know even when we look at social media, if we look on the news, that there's a massive highlight in terms of the ACL traction from the media is definitely there at the moment. And we know that the numbers of female ACL injuries is greater. For example, we know that the female footballers, they tend to have 6 times more And a really good example is in 2022, there was 57 ACL injuries across in female football. And a lot of the top England girls, they've come out in the press and they've asked for a greater clarity on what's going on. They've asked for more to be done within their sports, within their clubs, whether that be through medical provision. And really, as we start to focus more on the female athletes, it's imperative that everyone that is supporting these athletes, from the coaches to the support services, do they understand the female body, and where there are sex differences in the training, in the recovery, in the performing, injury, nutrition, etc. Do we truly understand, and do all the staff that support those players and those athletes understand? And really, the level of knowledge, even in the elite systems, from my experience, is still very low. And we may have this perception that the WSL has the more facilities than most. But actually, when you talk to a lot of these girls in these positions, they really don't. There's still a huge spectrum of facilities and support staff. And often there's, quite frankly, an inadequate medical support. So it's a growing level of football, and it's going to get better and better. But there's a fundamental issue, and that's the knowledge and the support to back that knowledge up. And as we look across the whole female research world, it's only 6% of the ACL research is done solely on females. So it's still a very under-researched area. And if you look in the last 2 years of research, it's definitely growing. It's definitely an area that's getting better and better. But overall, we have to build that research base so we understand more and more about the female body. And we understand that the focus has to be on getting them back to their sports. When you look at some of the other sports, for example, in basketball, for every 1 injury to a male athlete, there's 3.5 injuries to a female athlete. In volleyball, it's 3 to 1. And in recreational skiing, which is something that we do utilize the DonJoy braces quite heavily for, it's 6 to 1 towards the females. And of those people that do suffer an ACL injury, 65% will return to their pre-injury level of sport, and men are effectively double the likelihood of being able to do that compared to women. So there's definitely a huge gap. Now we can start to talk about kind of intrinsic and extrinsic risk factors, and what I'm not particularly going to discuss is the extrinsic factors too much. And we can perhaps discuss these afterwards if we want to. But training and game load, training types, surface type, shoe type, equipment, etc. It's a whole other topic, and we can go into that if we want to afterwards. What we are going to focus on is some of the intrinsic factors that we can influence through our rehabilitation. And these are some of the key intrinsic factors for female ACL injuries. And really, we can split this into 4 key areas. We can look at the structure, so we know the anatomical differences. We can look at the function in terms of what we can actually produce through our musculoskeletal system. We can look at movement, so we can start to think about how well we can control that body and the motor control, how efficient they are at that, the different planes, the different types of loads. And then we also have the other aspects that we can't not talk about, which is the genetics, the menstrual cycle, generally their cardiovascular fitness and local muscular endurance. Just looking at the evidence at the moment, if we just go into the structural side, for females and ACL injuries, we know that there's an issue with this narrow intercondylar notch. And we know that another big factor is this either posterior or lateral tibial slope. It increases that risk of and that vulnerability, particularly in higher and more violent positions. Generalized joint laxity and hypermobility is definitely heightened within the female side of our athletes and our patients. And a big one is that there's a difference in the anatomical sizes of the ACL. There's a decrease in that width and the volume of the actual ACL compared to males. And generally, joint shape can be different. That slight variation in the knee valgus, the knee varus, can have a significant impact on their function. And obviously, with Q angle, we know that that's something that has a big impact on that knee abduction moment. And we would typically describe these as non-modifiable. And I think that's been something that we've thought about, as we can't change for such a long time. But I think as we go forward in the research, some of these things are actually starting to be questioned, which we'll touch upon. When we come into the functional side, We know that there's differences in how much force we can apply, the impulse of that force, or the rate of force development. And this is something that recent research is really highlighting, which I will come on to in a little bit more detail. We know that there's those vulnerable classic ACL mechanism positions that can increase that tibial translation. We know that the moments and the initial contact upon landing, and the big theme for the female side is that knee valgus moment. And there's a disparity in the strength and the timing of the musculoskeletal system and how well we can produce forces at the right time. When we look at movement, there seems to be a trend, and research varies, but the trend tends to be the dominant limb tends to take more of the ACL ruptures compared to the non-dominant. I think that's situational sport specific more than anything. But we know from a motor control and a movement pattern, there is that high risk biomechanics. We know the knee valgus, that knee abduction moment, the hip rotation, the trunk lean, the pelvis positions, they have a huge impact on that risk factor. And then from really the genetic, the hormonal, and the metabolism side, a big factor for girls is that increase in body mass, or that BMI. We can touch on this hormonal influence, and this is something that we'll touch on today, just to have a quick discussion about. There's a genetic collagen factor when it comes to hypermobility and that generalized joint laxity. And a big one for us to really focus on in females is that local muscular endurance. There's a strong correlation between hamstring fatigue and that reduced knee stability for that initial contact at the point at which it ruptures. And I do think that to understand some of these factors, we have to go right back to how females and girls go through growth and maturation. If we can understand their growth and maturation as some of those factors, we can start to perhaps address some of these pediatric, these young ACL risks. And if we can start to implement changes at an earlier stage, we may have more success as they go through to high levels of sport. So with these two graphs, you can see this is a peak height velocity of both girls and boys. We know that girls will hit that peak height velocity stage, that puberty phase, far earlier than boys. And really, there's some distinct differences that can relate to our ACL risk when we go through our growth and maturation. So the other aspect that we have to consider is that difference between the early maturers, the on-time maturers, and the late maturers. That can have quite a significant effect on the types of sports they might play, and also the demands that they're putting through their knee. So briefly going through some of these key factors, when we look at the body composition, we get a big increase in fat mass for girls, even as early as 8 years old. They will get that full fat-free mass really by 14 or 15, but the fat mass after that continues to rise, and that's a hormone-driven factor. Whereas for the boys at about the similar age of 14 or 15, that full fat-free mass has continued to rise whilst the females stop, so they will continue to get effectively more muscle mass. And their fat mass will plateau and often decrease as they go through the final stages of their maturation. So the female that matures chronologically earlier, that earlier developer, may have an increase in risk because of that relative body mass and the load that they have to be able to control. For girls, the research has shown that by the age of 11, there's a difference in quadricep strength, and they've also found the same even as early as 8 years old in hamstring strength. Horizontal leg power plateaus and declines in girls, really through that pubertal phase to post-pubertal phase, so around that 16 years old. Whereas for boys, there's a linear increase through maturation. The muscle mass, the testosterone effect really plays into the male side. Knee abduction, the biomechanical aspect, the knee abduction angles, the moments, and the knee it basically increases as they go through maturation, as they grow. And that knee flexion angle, which effectively means they have a stiffer knee as they land on that initial contact, that continues to get stiffer in essence as they go through maturation. The key trend is that knee abduction moment. Whereas for boys, the kinematics generally stay the same. There's obviously outliers within that, but generally their knee dynamics, their biomechanical positions will stay relatively similar throughout. Boys, they have an increase in that ACL size and that notch width compared to the females. And for girls, that greater joint laxity is there, and it increases with maturation. whereas for boys, it tends to decrease or maintain at a level as they go through maturation. So girls have that increasing leg muscle mass to a point, and then it plateaus off, and then they get less strength and power when we're talking about pound for pound or that relative body weight compared to boys. So the amount of force that they have to produce is different, and this is it's a big factor. And you know, girls with greater magnitudes of knee laxity, for example, they will land with and have to use a greater level of muscle activation, try and create more stiffness. However, the demand is often quite high, so we have to ask the question: do we allow girls to get into that position where they are robust and strong as they go through maturation? As they're going through that maturational phase, obviously hormones start to play a big factor, and we can start to talk about the menstrual cycle and what effect that may have. And really the hormonal changes in the estrogen and the progesterone through the menstrual cycle, it's a huge topic, and it's been raised in the media time and time again recently. And it's a drum that's getting banged quite a lot, and it's quite rightly so. And there has been some research on this already, and they do show that, okay, in that late follicular phase, there perhaps is a change in muscle and tendon and makeup. There's the hormone relaxin slightly higher. And there's an argument to suggest that there's a higher injury risk factor in those phases. There's some studies that show there's some reduced neuromuscular control. However, really when we start to look deeper into this, and there's been a review done this year, a systematic review, and as you go through the systematic reviews, they can't conclude that there is a correlation between menstrual cycle and a risk of ACL injury. That's not to say there isn't, but the research is still just not there for it. There's also been suggestions that we need to look at the oral contraceptive, and there were some studies that show a decrease in the laxity of the ACL. However, the studies are of low quality, and there's some obvious ethical sides to that as well. I do think it's a promising area, and I do think it has to be considered, but I would place this in the world of those modifiable or those non-modifiable factors, much like I would talk about training load, much like I'll talk about the pitch surfaces, or as we go through a season, the changes in an ACL side. There's so many factors. I think when we look through the research at the moment, what we conclude is that it is a factor, and I think we have to listen to it. There's been some interesting work done at Chelsea Football Club, for example, and Manchester United's women's club, and they've experimented with trying to monitor it. So females are very knowledgeable now in those clubs of where they are in their menstruation. However, it's very hard to individualize. It's going to be very hard to take a team of 25 players and be able to individualize. So I think ultimately the biggest thing I would take away from this is you have to listen to them subjectively. They will have different effects. They will have different impacts on what they're trying to achieve. So if they're telling you they've got that energy deficiency, they feel really sluggish, and they are going through the menstrual cycle at a particular phase that is really making them quite low on energy, we have to listen to it. But I think it comes from subjectively listening and talking to your patients and your athletes. And the research is quite interesting, and they do talk about, okay, is there perhaps a phase where there is an increased risk of illness, or there's a phase where we can maximize strength, or there's a phase where perhaps we have an increase in injury risk. Every cycle is different, and it's going to change. And if you talk to any female, their cycles change on a monthly basis. Every cycle could be significantly different, whether they are using a contraceptive device or not. I think, you know, we can't use a universal blueprint, and I think we just have to consider that we have to use our subjective side, our communication with our patients. So can we have something that exclusively directs our training, nutrition, rehab, and performance? I don't think so yet, but I do think it's something that we can have in our armory. I've had an example of one girl recently who has had multiple almost niggles, little injuries through her ACL rehabilitation, and actually when we sat down and worked it out, it did tally with some of her cycle. So it's a factor that we can start to consider, but again, it's very subjective. And on a case-by-case basis at the moment, I think. The other side to this is that we do have to consider the gendered environmental approach. So Parsons in 2021 did a very nice study which weaved in this gendered environmental approach to ACL injury and management. And really approaching ACL injury prevention and management with a strictly biological view can propagate the sexism within sport, and it can be quite detrimental for girls and women. One case, there was some research that suggested that all girls should be using the oral contraceptive pill to prevent injury. There's obviously ethical issues. And another case, which was done in Aussie rules, women's Aussie rules football, where the response to the high numbers of ACL injury rate was to simply apply the default response of we have to investigate menstruation. And really, it places female sport in a dangerous place, because the message was, you know, it's sports are dangerous due to female biology, and it just creates and adds to the wider general social context of labeling women being not naturally fit for these sports. It's too dangerous. So I definitely think it's something that we have to consider, both within our rehabilitation settings, but also as they move back into their sports. This can occur from our younger years, so even the pre-sport years. So the gendered socialization of throwing like a girl, to make the cases to how gender socialization manifests in how well girls can control their body or their spatial awareness. You know, from birth, there's gendered parenting, and it's quite implicit. So, for example, purchasing different toys or allowing greater independent mobility for boys versus girls. It's the classic thing of boys doing the rough and tumbles and the girls doing the arts and crafts. I'm a father of two girls, and I've got two distinctly different girls. One who is very much quite happy to sit down and be very artistic and read books, and the other one who is more rough and tumble. So it's very interesting to watch children grow, and how you parent as to what influences you can put into them. And this can go into, you know, infancy, childhood, in schools. What skills and what skill sets are we giving them, and what effect does this have, and does this alter their movement patterns in sport later in life? So a classic one would be, well, what age do boys typically start playing football? 5 or 6 years old most of the time. At the moment, if you go into a football academy setting, it is as young as 6 years old. Whereas for girls, it tends to be 10, 11, 12. Well, a lot of girls are going through their peak height velocity at that stage. So we can see that there is this environment that we might call the motor control gender gap. Boys are starting at a much earlier age. They're being exposed to agility, sidestepping, you know, environmental situations in multi-directional sports that females may not. So it does render the female as presenting as more susceptible to injury, in essence, in the realm of sport. And this is really driven by our expectations, perhaps. And this comes into the training environment as well. This is still very much the case that an increase in muscle mass is not seen to be socially acceptable or desirable for girls and women in sport. And if you talk to a lot of them, they don't want to get too bulky. There is this perception they're going to get too big. And there's the hashtag strong not skinny, which I think is very interesting, and that's been a welcome change. But social media does also play a part. And we have to consider both the positive and negative sides of that. And if we are asking them to get stronger, and we are asking them to build that strength that's going to help them to reduce their risk of ACL, when you go into a weight room, a gym, and even at the professional level, it's highly gendered. It's still a very male-dominated space. And if you talk to a lot of women, they do not like going into that section in most commercial gyms, because it's an intimidating environment. And this is something that we have to address. This is something that we have to think about when it comes to our rehabilitation. So those are some of the aspects that we need to think about in terms of the risk factors and our training environment and our rehabilitation environment. And we have to put some of these things into to context. Are we allowing these girls not to be in the environments where they are able to fatigue their bodies, they are able to do more twists and turns that may increase the ACL size, that may lead to more development of these previously thought modifiable factors. Could the bony morphology change if we challenge it, in essence? So we need to think about what we're doing in those younger years. But really, moving into our kind of ACL world, I think it's worth us coming back to this fact that ACL injuries are a brain injury. It's a neuroplastic cascade that occurs. Our ACL is highly innervated with mechanoreceptors. So we have to consider what effect does this have on our nervous system. And there's some fascinating work done by Groom in America, and they've done lots of different studies studying brain activity. And the image on the right shows the brain activity of someone standing on one leg, and the top two are this non-athletic person, and then you've got fencers and you've got karate people. The main thing to consider is that when you are neurally efficient at a skill, you use less areas of your brain, so you have this neural efficiency. And what you can see as you go up through those brain scans is that the karate players have a smaller, more subtle area of activation, whereas the people who are non-athletes tend to have to use more diverse areas of their motor cortex to do the same movement. They're not as efficient in bringing those areas of their brain activity into one place. So ultimately, when we have this ACL injury, that sensory cortex is stopped. The body has to rely on something else. So it will use the visual and the vestibular systems more. So it has to use more areas of the brain. And I think this is something we often forget. We often think of it being very biological, particularly from a rehabilitation perspective, is, oh, okay, the ACL is now fixed. But actually, the brain doesn't know that yet. It still isn't aware if we can get that sensory information there. So it's going to continue to try and find a different way. And you can look at this as a cascade, really. So once the ACL is ruptured, we get that mechanical instability. The mechanoreceptors are no longer sending that signal back to that in that spinal reflex or up towards the brain. We get the local inflammatory mediators that will play a part in this as well. And we lose that spinal reflex, and we have less of an ability to produce the motor signals. And we're just receiving less information. So the whole motor unit is completely disrupted. And ultimately, this is what arthrogenic muscle inhibition is. This is truly what happens. It's genuinely a block. There's a decrease in that afferent input. So the brain will change. It will have to generate a lot more neural activity to try and find where that knee is. So two key things will happen from that. You will get that sensory loss, and also what we call M1 excitability, basically meaning to produce the same sensory feedback, to produce the same muscle activations. The brain has to use more areas, and it has to use it almost more densely to try and produce the same movements. So this isn't just a localized weakness around the knee. This isn't just a localized loss of proprioception. This is the brain itself in its movement patterns. It has changed. And a nice graph, which was done quite some time ago, but it just illustrates it nicely, is after an ACL lesion, you can see on that top left side, the level of activation to produce movements changed. It was highly, there was a lot more activity to produce the same movement. And there's a really interesting study that was done that took some female football players or soccer players, and they classified them into a high and low risk category, and that category was based on the knee abduction moment. So you can see the fairly obvious knee valgus position on a drop jump landing compared to a fairly neutral position being a low risk. And what they found is really interesting, because they looked at the level of brain activation, and in the low risk group, what they found is that the blue areas they activated, but they activated less of those blue areas, whereas the high risk group activated those blue areas, but they had to activate them far more. So there were far denser levels of activation, but they also had to increase in those red areas. So what they found was that the high risk strategy had to use more of the sensory and motor cortexes. It had to find more areas of the brain to produce the same movement. So it's a really, this high risk movement pattern, it's interesting because it raises the question, was that there before an ACL injury occurred? Because they're looking at girls here that don't have an ACL injury. And did it happen before? It highlights that we need to address the brain within our rehab. And it also really highlights that we have to focus on this to prevent the secondary injury. So we have to consider the motor cortexes, we have to consider motor pattern learning, and we have to prioritize that within our rehabilitation. And really, if the motor task is the problem, and we've got this altered brain activation, then the solution has to be in becoming more efficient in those movement strategies. So let's talk about some of those movement strategies when we look at the female ACL injury. We know that there's a pattern. We know that when we look at the female side, there's two distinct patterns that occur. So the top left, the A, B, C, and D is an example of a defensive pressing position. It's a rapid deceleration. There's a visual distraction, whether that be for the ball, whether it be for the player. There may be some direct or indirect contact that throws them off. But ultimately, what they will do is they will go into that position where the leg is slightly more extended. They will increase their knee abduction moment. The hip will internally rotate. Their body will lean away. And ultimately, they go into that vulnerable position that increases the tibial translation. There's two cases recently. So the next three images down, the E, F, and G and H is actually when someone's controlled the ball and then they plant their foot down. Same mechanism, but it's just the loss of stability. The number 9 there, you can see the three images below that is Beth Mead, Arsenal player recently, which did involve a slight bit of indirect contact. Whereas the one at the bottom, which is Laura Weinrother, which was done quite recently, this was an interesting one because the player in green actually just played the ball past her. So she actually ran past the ball. So her visual cue was to follow the ball with her head, to rapidly decelerate, rapidly single leg load on her left leg, go into that knee abduction moment as she shifts her weight. So we know that there's a multitude of factors that come into this. There's a rapid deceleration, there's a single leg loading. Within football, it's often a defensive pressing position, often at high speed. The big thing, there's a visual distraction. So this draws us back into this neurological world. And there doesn't always have to be a contact. So your movement pattern is fairly typical, and we see this quite often. And this is a nice image that really summarizes it quite nicely. I think what's interesting in one study done last year was they looked at secondary injuries of ACLs. And what they found is that when we look at the mechanisms that are occurring in the female game, there's some really startling statistics. And it's, again, that defensive position. It's that single leg landing. It's in a cutting and pivoting action. And their key visual cue is the ball. So we have to start to look at these neurological factors and these body positions and how we control the forces in those vulnerable places to be able to withstand. You know, if we're getting these re-injuries from the same mechanisms, more so really even, we're missing something in our rehabilitation. We're not doing something to really change that effect. And a really interesting study that backed this up was, and this was done last year, is they compared lab-based cutting and pivoting and deceleration, and they actually mapped it against the field-based as well. So it compared the two, and it was a fascinating study because ultimately what it showed is that the stuff that's done in the lab can almost over-exaggerate what happens on the field. But to quantify this further, they found that there was 3 clusters, and this is really interesting. So cluster 1 is what they deemed the lowest risk. And in essence, they had very good biomechanics. They had the lowest peak knee moments in all 3 planes. It's considered a low risk. And if you can see on the graph, when you hit a force plate, you can see the yellow line that comes up. And that's the ground reaction force. And what you can see within them is that ground reaction force is very much within their base of support, and it's actually quite low. It doesn't go very high. So they have a good ability to get into the knee and change direction and accelerate out of the knee. They can absorb that force and change direction. If we skip to cluster 3, that's our highest risk. They've got the highest demand on their knee in all directions, both in frontal as well as in like a transverse plane as well. And what they had is they had a significant increase in that knee abduction moment, so effectively that knee valgus. They had a stiffer extension moment, so they effectively don't absorb the force through the knee. There's that big increase in hip movement. They had increase in ankle eversion, so it comes down to that foot contact as well. But you can see if you look at that yellow ground reaction force line, it's huge. Okay, it's in their base of support, but they have no ability to absorb that force. It's a very high speed motion that they're unable to control. And the interesting thing was what they found in the lab followed through with this cluster on the field. So when they were twisting and turning on the field, exactly the same mechanics. So we have, again, this higher risk group, which correlates with a very similar pattern with that neurological high risk group as well. The second cluster was slightly different. This was more about having a stiffer knee. So you can see the ground reaction force is higher. So that initial contact point, they're still taking a huge amount of force. They have a better control of that knee valgus, but ultimately they have that stiff knee moment. So we can start to understand the differences. If we are unable to control the forces like the third cluster, and we have a very stiff position, we cannot control the force going into the ground as well as the force coming out, then the demand that we're going to place on our passive system significantly goes up. So if we're looking at the most vulnerable positions, which is that deceleration and sidestepping, another good study looked at the total contact force that we might get on the tibiofemoral joint, looking at medial and lateral loading. And what they found is that deceleration is about 11.5 times your body weight as you're going through it, and sidestepping is about 13 times your body weight. And this is a 90-degree cut, and it's a straight deceleration. It's interesting because the initial part of braking in deceleration is revealed as the most dangerous. So it fits with that initial contact. As soon as you hit the floor, it's the same in both for males and females, but it's that initial contact in both deceleration and sidestepping. So it's that point of, as I hit the ground, can I absorb that force? Do I have this pretensions to control it? As you go through into deceleration and sidestepping a little bit further, what's quite interesting is that as you land and you take that initial contact, you'll go from a medial compartment loading to a lateral compartment loading. So again, if you've got this increase in knee valgus, you're going to load that lateral compartment far quicker. And I think what I found quite interesting in this one was it was a study where they actually then took the data and they manipulated the various valgus moments. They changed the tibial slopes through some very clever computer techniques. And what they found was in the slightest changes in the tibial slope, it increased that lateral compartment loading. So if we have someone that has a lateral tibial slope or a posterior tibial slope, and they have a knee valgus, the speed at which you go from a medial compartment compression to a lateral compartment goes drastically up. And the only thing that stops that pressure is the ACL. So we're continually seeing this mechanism reoccurring. So how do we control that? So we can look at some of the muscles that we need to focus on. And this is two different studies done by the same research group. And they look at both the knee spanning and the non-knee spanning muscles, so muscles that cover the knee and muscles that don't, in essence. And what effect do they have on the ACL? So what's quite interesting is, in particular, on the left side, the hamstrings, the soleus, and also the glute med appear to have the greatest ability to oppose the ACL loading. And really, the hamstrings are a key factor in controlling this knee valgus, but also this posterior shear force of the tibia. So we need to be able to unload that ACL, so the hamstrings become really, really important. However, it's less effective. These hamstrings are less effective in that kind of 20 to 30 degrees of knee flexion. Again, this vulnerable position. And one of the noteworthy findings in this study is that the glute muscle group is capable of generating a various knee reaction moments. So our glutes can really play a huge part in restricting that knee abduction moment. And the net valgus joint reaction moment during that final 25% of weight acceptance and side cutting comes from the hip and the pelvis. So really what we're saying is we can focus heavily on our hamstrings to control that motion and deceleration and change of direction. But we also know the quads, as you can see, the quadriceps in the middle there have very, very big circle, meaning it has a bigger effect. But ultimately, we know that it will only allow us to have that ability to decelerate and shock absorb. Everything else around it is going to play a huge part in controlling that knee. So if ACL injuries occur within that first 15 to 50 milliseconds of that initial contact, can our neuromuscular system cope and prevent the ACL tension? Well, we know that it takes about 50 milliseconds for our system to actually recognize that there's a change in our mechanics and this is a vulnerable position. And it actually takes another 50 to 70 milliseconds to generate force to come out of that position. So if we're only relying on the reactive side of our neuromuscular system to save the positions, it's simply inefficient. The feedback is too slow. So a big part of what we have to do to enhance our rehabilitation is we have to focus on this feed forward activation. And it backs up this neurological side of our rehabilitation. We have to have this pre-activation. We have to have this neural drive that's already there that can help us in this vulnerable position. Yes, strength is a big factor and we have to be able to absorb that force. But ultimately, if we don't have that pre-tension there, it's going to be too slow. And this is perhaps why we sometimes see in our athletes who are perhaps slightly more hypermobile or they don't have the required strength. The research consistently shows that there's a change in hamstring activation. It's a little bit too sluggish. That may be one of the reasons. Do we have this feed forward mechanism? And something I focus on quite heavily in my rehabilitation is this kind of intra or intermuscular coordination. Can we look and get this body to actually move in a coordinated fashion? We have to move past this purely physiological constraint and bring in the sensory motor learning system to organize the movement. We also have to recognize that our passive structures are essential in this. So we even from your hamstring intramuscular tendon, your patella tendon, these are huge force generating tissues and they react exceptionally quickly. So ultimately what we have to have is this ability to co-contract. So you can see on the top left of the image there is what they call the 4-bar complex or 4-bar system, which is, okay, well, if we consider the hamstring and quadricep relationship, are we able to control at the right times when we're running, when we're slamming the brakes on, when we're twisting and turning? Do they work together to provide the right level of movement? Are we sharing the loads? So as we run through, are we sharing that force up through the Achilles, the soleus, the gastroc, the hamstrings, the quads, the glutes? Is everything working together at the right time? So co-contractions is something that I work on quite heavily. And it's seen in these both ACL recon patients and also ACL deficient patients that there's the higher levels of functionality demonstrated increased hamstring prep activity accompanied by greater ability to control that tibial force, basically saying timing. So if we can get the timing right, then we're going to have a really good effect on these ACL either deficient knees or also these rehabilitation ACL recon knees. So co-contractions increases that joint stability and it gives us that pre-tension before we hit the ground. And to do that, we have to consider this coordination and how confident we can put these patients through their different exercises. So if we just focus on force production, it's not going to lead to an improvement in performance. So we have to consider how can we have an environment that teaches them that self-organization and leads to that functional output. So we have to have the right task, we have to have the right environment, we have to have the intention that, to do the movement, and we have to have everything around their body working for us at the right time. Can we then teach them to self-organize? And to self-organize, we have to consider the task that we're giving them. And this is something that I've focused on quite heavily for a number of years now. And I'm a big and I will use a lot of these tests. So for example, isokinetic dynamometry, jump testing, hop testing, landing tests, change of direction tests. But ultimately, they are a measure of motor performance. And performance is the ability to perform that specific task. And it is open to manipulation. I can get someone on an isokinetic dynamometer and I can scream and shout at them, and I will make their arousal system increase, and I will effectively get a better score. But does that translate to everyday regular movements that they're going to be performing out on the pitch, on the field, on the court? Perhaps not. So we have to consider this motor learning and the transfer of those movement strategies to make it automatic. So arousal plays a big part in that also, but the complexity of the task as well. So we want to deliver the right exercises at the right time. So early in rehab, we might make that task quite low in its complexity, but it will give them a very high arousal state. They feel confident. And as we go through and we build that complexity, then we're going to make the task harder, and we're going to challenge that arousal. So we do the right tasks at the right time, and we're going to get that nice transition from being not just a performance measure, but also it transfers into their everyday movement. So ultimately, the key things that I want to raise is that we do need to recognize the growth and maturation, the social and cultural and gendered influences that they may lead to the motor control gap for them. So we recognize that females may be going into a sport with pound for pound less strength, body control, muscle mass, power, the ability to control their body. And there's biological as well as social areas that we need to consider. And we have to consider these within our rehabilitation. And can we create the right training environment to give the positive messages? We need to come back to this point that it's all about the brain and what goes in and what comes out. So we have to train that neuromuscular system from the very beginning. We have to get over that arthrogenic muscle inhibition very early, and we have to do it throughout. It doesn't just stop after the first 4, 5, 6 weeks. This is a year-long, a 2-year-long process. We need to recognize those at-risk movements, and we need to get strong. And we need to get strong, not just going into them, but we need to get strong going into them, going into the vulnerable positions and getting out of them. So they need to be strong in all positions throughout. It's not just about quads. We hear this quad is king, but ultimately everything else is as well. We have to get everything as strong as possible. And then we have to do this feed forward mechanism, and we have to create this self-organization. So I've got a couple of videos that I want to go through that highlights this really. So this is a case of a young girl who had an ACL reconstruction, and she plays in a professional football club, and she had an ACL reconstruction. And to give you context, she had a bit of a meniscal repair. It wasn't a huge meniscal problem, but she also had a lateral tenodesis as well, which I'm a big fan of, which I know Mark can back me up on. They're exceptionally helpful for rehabilitation. So I'll go through, I'll try and make sure we haven't got any sound on these, because otherwise you'll hear my voice in these rehabilitation videos. So we're going to start off with, from the very get-go, we're using that muscle stim, and I'm a huge fan of this. I will get the muscle stim on them early, and I will do it as much as we can, multiple times throughout the day. We want to really push them into this, let's get rid of this arthrogenic muscle inhibition, and let's work on it straight away. So at this stage, what she's doing, she's about 3 weeks post-op at this stage, and we're just integrating some very simple movements on the knee. You can see she's still quite flexed in that position. It's an uncomfortable thing for her to do, but we're working through, we're getting some quad activation and just getting some sensory feedback. So we're stimming straight away. We then back it up straight away. So this is the same session. We're then loading in some very simple positions. The actual task of this is more about trying to get terminal knee extension, which you can see she can't get yet. She's still a little bit swollen, but we are working on trying to get some changes in some activation. This was a week later, where ultimately she was then able to get a little bit more movement. She's working up into that terminal knee extension. So we're just consistently barraging the neuromuscular system constantly throughout. I'm a big proponent, and people get bored of me saying it, but I talk about repetition, repetition, repetition. And I don't tend to set sets and reps in these early phases. I just want to influence and barrage their system as much as possible. Obviously, if they're struggling and we're thinking about different levels of swelling and we are listening to the knee, obviously, but ultimately what I want to do is make sure that we are getting as much into that system as we possibly can. Then as we go through, we start to integrate the whole body. So this is a couple of weeks after that, we start looking at a few positions whereby what we're doing is we're trying to integrate the whole body. We're trying to create these co-contractions to start off with. So this is the basics of what we call a leaning tower, where we're just getting her body to create some stiffness through her trunk. And then we progress this where we start to take her into some very simple movement mechanics. We're trying to get her hip to come up into what we call a hip lock position. But ultimately, you can see she's trying to create this co-contraction through her body. So can we get a bit of calf activation? Can the hammies and quads work? Can the glutes work to stabilize the pelvis? You can see her left arm is back. So we're creating this trunk stiffness at the same time. We're integrating the whole body from a very early phase. But it doesn't always work. And this is an example of the complexity of the movement being too hard. You can see she goes to step up and she has not a clue. Her body is confused. It is baffled by the stimulus that needs to go into it. And you can see it's very uncoordinated and a hard thing. Now, a week later, as she started to work through it, we then starting to get this neural efficiency. She's starting to get these movements that look a little bit more efficient, a little bit snappier, a little bit sharper. And we start to work on this ability to co-contract. So we want to make sure as we go through, we have these little pauses at the right time to get everything to work together and get this intramuscular coordination. And some of the tools that we do this with, for example, is we have an isometric work that we do. So this is an ankle isometric. So if any of you are familiar with Alex Natera's work on running specific isometrics. So this first one is she's pushing up into the bar as hard as she can. Her heel is off the step. She's creating the force that goes up through her gastroc, through her hammy calf. It's a whole leg movement. She's flexing the other hip because we want to get this hip lock position. So we want the hip and the glutes and the hip flexors to work at the same time. And she's pushing as hard and fast into the bar as she can. We also do other activities such as isometric split squats, which again co-contracts and works everything through. And then we also start to work through hamstring work, where we might start looking at simple movements of just creating knee stiffness, getting those hamstrings to activate at the right time. It's all about this coordination, and we might even still work through some basic things all the way through. So this is an example of controlling the body through a hip lock position. The left leg is still working through. It's getting that extension, almost a triple extended position. But we're constantly trying to get this muscle activation at the right time. So this is an example of trying to control this hamstring switching on and trying to get just this little bit of activity. And you can see it's hard. She doesn't know where the foot's going. It's a neural problem as she starts to get better and better at it. But you can see it takes a bit of brain activity to get there. And we work through. Should we start to speed this up? We start to change the speed of it. So now we start to add a bit of perturbation into it. She has to control her body position. She has to really work through the coordinated patterns that we might see in a running activity. And when we start to add in different movements, different transverse planes, we start rotating a little bit. All of it's about creating this stiffness at the right time. And then you can see a few weeks afterwards, we're getting very neurally efficient. She's stepping up, she's moving very quickly. We start generating higher levels of force, and we're creating the right level of co-contraction through our body to control, and it just looks easy. And that's what we're looking for, is that free and easy movement. But we're still lifting, and we're still working on speed. We're still working on that heavy load of strength. So I'm a big fan of a step up, which if you follow me on Instagram, I do a hell of a lot of step ups, because bang for buck, it is one of the best exercises to get that glute engagement and control that pelvis level. And as we go through, we start speeding that up into our deceleration. So we start to go into things like a plate punch, which is to come down and creates that knee stiffness in those deeper ranges. We add different planes of motion into that deceleration. So we're controlling the knee as it's going round. And ultimately, it's about controlling the whole body. So again, she's in a plate punch position there. And it's about creating that stiff knee position. Then we start speeding it up. Can she control that initial ground contact? We're working on the co-contraction. So to control that position, she has to start working into a bit of terminal knee extension, perhaps. So do the hamstring switch on to control it. And we add different perturbation into it. So it's all about this initial contact. Can we get the hamstrings and quads and glutes and calves to switch on at the right time? And then we go complex with it. We start going into what we call a Bosch clean, for example, which is where we're asking her to lift, create lots of different movements throughout the whole body. Ultimately, the aim with this is to create this extended position through the hip. And she has a little pause before she goes onto the bench. And that pause is designed to create a co-contraction through the hip and pelvis and hamstrings and calves. And then as she hits the actual bench, what she'll do is she'll have that hamstring activation to create that knee stiffness. And then we also have the motions of creating some rotation through it as well. And it's a complex movement. We're trying to do exactly the same movements, but we're adding rotation into it. Then what we do is I like to change the environment. So I have a good relationship with a local gymnastics club. And what we do is we throw them into different settings and different surfaces, and we ask them to do exactly the same things now, but now we're getting different feedback through the sensory system, and it's hard work. But it doesn't have to be all drastic things. Even on the beam, it's just the visual aspects of being higher up, for example, but we're still working through coordinated movements. So the idea here is to try and dip down, and as we come up, can we get that calf to bring us up, quad activation, hamstring activation, sensory overload all the time. And then, having worked with a lot of gymnasts, I can tell you footballers do not have any ability in gymnastics whatsoever. And we've tried many times to get them better at simple body movements, but some of them, they really struggle. So gymnastics is a lovely environment. If you have a local gymnastics club, I can't recommend more than building a relationship with them to see if you can take some of your patients or athletes down there to rehabilitate into. And we work in vulnerable positions. So this is another girl with an ACL rehabilitation where we're asking her to go into those knee valgus positions. Can she control into those deeper ranges? Can we get really into that hip adductive position and that valgus position? It looks quite a vulnerable place to go. The band is pulling her across, but she has to try and control that eccentric movement. And actually, it's a very powerful exercise to develop that motor control in those deeper positions. And we fatigue it, and then we really push them. So we're still working on this neural efficiency. So yes, this is going to work on that muscular endurance and that fatigability, but ultimately I now want to put them in a vulnerable position whereby they're working as hard as they can. And then after this, for example, she'll do this movement as fast as she can, and then she'll go into a controlled movement that she has to challenge herself with. Equally, there's another one which is a higher eccentric and isometric overload. And she's got to get that turnaround. She has to bounce up and down as quick as she can. And ultimately, this is highly fatiguing. And I like to superset these with a movement afterwards where it challenges that control and that neural efficiency. And then going back to this modified Bosch clean, which is she's going from a very deep position in one place. So we're going from a very hip extended position, hip flexed position on the front leg. So she's from a hip flexed to a hip extended. So we're taking her through that full range. But throughout all of this, we're still working on this heavy load of strength. We want her to load. We want to build a really strong base. And throughout all of this, it's about creating that, for me as well, in the female world, it's that body positivity. This athlete enjoyed the fact that she was getting strong. She could see the physical difference. And I think with a lot of the top female footballers, for example, that positive body image of being strong is having a very positive influence on a lot of these athletes. Deceleration, we're challenging that deceleration, and we're challenging some of those forces before we go into sidestepping. Triple hops, for example, a really nice way to control it. I like to overload that eccentric component of deceleration. So use the band to overload, and can they go into this deep deceleration? Can they slam the brakes on as quick as they possibly can? Can we overload that single leg position, for example, with an overbox jump and a plate punch? She was yapping away here. Hold on, she'll do it in a second. She'll jump over the box and plate punch, and it's just overloading the system. But we also, with this one on the right, might do this this step up activity with a perturbation. So this self-organization becomes a big component. So as we come up, can she self-organize? Can she control the perturbation that comes into it? Overbox jumps are a big favorite of mine. So can they control that harsh deceleration? And we might take this a step further by asking her to go over the box and then get back on the box. So can she decelerate and accelerate out of that position? And another one, and this is also a study that's done recently about lateral hopping. Can she self-organize? Can she challenge herself in these positions to go from side to side? So I know that's a whistle-stop tour through these factors, but what I really wanted to highlight from my perspective is that, again, as we go through those key points, we have to understand the environment and the environments that they've been in as to how much we might be able to influence and change. Simply saying get strong isn't good enough, and we have to start to consider everything around their social and their cultural environment. And throughout rehabilitation, for me, most rehabilitation is neurological, and the byproduct is getting strong, getting powerful, and getting quick. So if we can challenge the brain, we're going to overcome that inhibition. We're going to remap the brain, get strong movement patterns. And that follows through into those next phases of getting out on the training pitches, out on the courts, where we start to go through those harsh and multi-directional twists and turns and start adding in the visual cues. We have to think about the brain as an input-output system. The at-risk positions are a nice place to build your rehabilitation from. But ultimately, if you can, from the very get-go, challenge the nervous system and train those feed-forward systems and those intramuscular and intermuscular co-contractions, I believe we're going to develop a body that's going to be able to self-organize better and self-organize under fatigue, and give them that variability that they need to have for their sport. Okay, so thank you for listening to my thoughts and delving into some of the fascinating world of the female ACL injuries. If you want to listen and look at some of the other stuff that I do, I'm probably most vocal on Instagram. So I'm at Mr. Jimmy Reynolds. I am on Twitter. I am on Facebook under similar names, but most of my stuff goes on Instagram. If you have any questions or want to contact me, my email address, jimmy@alphaphysio.co.uk. Feel free to jot that down. Ping me an email if you want. I'm more than happy to chat. Ultimately, I am a geek and I will chat all day long about ACLs. So thank you for listening to everything I've been rambling on about, and I hope that was useful. And I will hand it back and see if there's any questions that anyone wants to ask.
Yeah, Jimmy, so thank you so much for that. And I'm sure everyone in the audience will agree that was a fascinating insight and just some real relevant info. There's so much to go after there. So really hope we've got some questions. Craig's going to join us now, and so is Mark Bowditch to help moderate this. There is a question in the chat, but I'll leave that for Craig. And if anyone as well has any other questions, please do put it in the chat. Or if you would like to raise your hand using the function there, then we can unmute you, and you're welcome to jump in and join the discussion as well. So again, thank you, Jimmy. That's fantastic. Craig, I'm going to pass over to you as well, and obviously welcome Mark as well. So thanks so much.
Thanks, Sam. And yeah, again, thank you so much, Jimmy. Amazing presentation. I think I know I've got a million questions to ask you, but I think it really highlights the complexity of ACL injuries and how many sort of factors there are involved in sort of the rehab and, you know, getting people back to playing again. And yeah, as I said, I've got sort of lots of questions, but I know, again, just to sort of your Instagram, if anybody needs any inspiration for exercises for their ACL patients, Jimmy's Instagram is a sort of never-ending stream of variations on exercises that you would never have thought of. So just to kick us off, so we've got a question from Karen. So Karen sort of asked, and I can put this to both of you, but we'll start with Mark. How do you feel about hamstring or patella tendon grafts and the impact on whether the graft is taken from the same or the opposing side?
I'll let Mark come into that.
Well, hi everyone. Can you hear me?
We can, yeah.
Fantastic, and thanks very much, Jimmy, for a fantastic talk. I learned lots as well. It was great to see. And it's very, very timely, talking about the instance of female ACLs. I don't know if any of you saw the Sky programs yesterday, and it's something that ourselves at the British Orthopedic Association and British Association for Surgery of the Knee are really focused on, because of the interest and increased uptake of football in this country. We're seeing huge numbers of increased numbers of ACL ruptures, which is a great shame, and we're trying to focus on prevention. And a lot of what you said actually applies to prevention, particularly perhaps less so on the elite, because they're already doing all this neuromuscular work that you've described in great detail, and that is absolutely the key, and key going forward for the everyday competitor. In terms of hamstring or patella tendon, most surgeons, I guess, will have their favorite go-to graft, and that's how it evolved over the years. But these days we're learning that we need to have various graft options to suit different individuals. A personalized type care package is more important. So in sprinting sports, we tend to not take the hamstring. The hamstring is really important for sprinting sports. So like football, we're veering away from hamstring back to the extensor mechanism somewhere. Patella tendon is the commonest, sometimes quadriceps. Whereas in jumping sports, you need your extensor mechanism perhaps more. And whenever you take a graft, there's a 15% donor loss of power to some extent. So jumping sports, netball, basketball, we tend to consider more towards the hamstring. And I think that's what we're learning, that you need to have a variety of different types of options and go through that with the patients. And there's quite a good scoring system called the Moon scoring system from the US, which you enter a fair bit of data about your individual patient in front of you, and it comes out with your risk of re-rupture with the different graft types. With respect to graft from the same or opposite side, most people tend to consider that they've got one injured knee. Why do they want to injure the other knee by taking a graft off? So certainly in the UK, it's generally same knee. There are obviously circumstances in which you might consider the other side. For example, if you've got combined ligament injuries, and if one had someone with an MCL injury or posterolateral corner, you might need to use the hamstring for something else. So generally not. We moved a bit more towards using the lateral tenodesis, lateral extra-articular tenodesis, which you may be familiar using IT band, particularly in the higher or elite level patients or revisions, or what we call high risk under 25, high risk pivoting sport, hyperlax, particularly those perhaps with an increased tibial slope. You mentioned tibial slope. We're looking at that much more closely than we used to. More than 12 degrees of tibial slope makes one worried. I'll stop there so you can answer more questions.
Perfect. Thank you so much, Mark. And I mean, from your perspective, Jimmy, do you sort of have any preferences? Do you see much difference in the sort of rehabilitation side depending on sort of which graft is used?
So the main factor really from our perspective is just the soreness of a patella tendon one. To be honest, most of the time I don't have many issues rehabilitating a patella tendon one. They'll get that initial soreness and kneeling on it's particularly painful. But if they go through a structured rehab, actually they will get a gradual increase in the tensile strength of the tendon quite quickly. I think the really relevant thing for the hamstring graft is they have to get that activation back. So, okay, we've taken some of the graft away, some of the hamstring tendon away. So we have to ensure that there's no inhibition that remains in that hamstring mechanism. So when they're making that initial contact on the ground, have they got that hamstring that works hard enough? And some of your testing can highlight that. A Biodex and isokinetic dynamometer can highlight that sometimes, depending on where the weakness in the hamstring is. So that can be quite helpful. But I think from my perspective, they do have their unique little challenges, but ultimately they kind of merge together in their rehabilitation.
Yeah, after you sort of get over those initial differences towards the latter parts of rehab, once you've addressed those, it sort of comes together. And just to circle back to something that sort of Mark mentioned, you know, the program that was featured on Sky Sports and talking about the Power Up to Play sort of group, compared to 20 years ago, there's a 29 times sort of increase in the number of ACL reconstructions being done in sort of younger athletes. So it's a huge sort of challenge that, as Mark mentioned, the BOA and BASC are looking at and sort of trying to address that and work out sort of what those causes may be and how we can work on it. But moving on to another topic, because I'm sure we could speak about that for a lot longer. One of the questions that we've had come through from Harriet is about using NMES. So she's mentioned about using muscle stimulators. She says, probably more so towards Jimmy for this one, but do you utilize it just in the early stages of rehabilitation, or is it something that you use all the way through their rehab?
So I will use it heavily in the early phases. I will often use it with occlusion at the same time. So I'm a big fan of, in those early phases, using occlusion therapy. So occlude the thigh in essence, so reduce the blood flow slightly to get a massive hormonal change. So that when we use some simple muscle stim, you get a very drastic hypertrophy effect. It works exceptionally well, and you start to get maximal muscle recruitment far quicker. So I'll use it very early on. I will use it really up until the point where I can challenge the system enough within, say, a gym setting. So if I feel like they're still lacking in some of that hamstring or quad strength, I might still ask them outside of rehab to still gun it as much as they can. And particularly with those joint lax, hypermobile patients, I will try and create as much activation in their system, because thinking about it neurologically, the more I can put into them from any system, whether it be artificially in essence, we're still going to create that reflex loop and that brain excitability. So I will use it probably, for most people, if I was to put a time frame on it, up to 2-3 months. So I do encourage them to get their own, because then they can utilize it. Or they can rent them from us, but ultimately we'll try and get them to use their own.
Perfect, thank you. And I mean, a question from my side, something I'd be really interested to hear from both of you about is, in terms of the patients that you're seeing presenting to you with ACL injuries, what sort of percentage, what mix are going down the conservative route versus surgical route? And are there any particular criteria that you're using to help sort of determine that? If we go to Mark first.
Okay, well, I probably get a bit of a biased group because natural self-selection. I'm a surgeon, and so I get a lot of physiotherapy referrals. So often that decision has been made. There was a good paper called SNAP, S-N-A-P-P, out printed in the Lancet, I think it was last year, which actually very clearly gave evidence that ACL reconstruction works. So we feel quite pleased about that, of course. What it said was that probably about 40% might be suitable for a non-operative course to start with. That's often the period of time that we should suggest that people get over the acute injury. Really needs to be with the physiotherapist. The key to get the muscle stimulated, and then they've got to understand what they might let themselves in for and work out, do they really need it? Because just because you occasionally play tennis and you've injured it going skiing for the first time ever, you may never go skiing again. And you may actually do extremely well with an Enovis brace, for example, in your summer tennis sessions next year. So don't rush into some patients. Obviously, if you play for Man City, male or female, you're not really going to get back to that level, probably without an operation. So look at the individual in front of you and decide. I'd spend quite a bit of time talking some patients out of ACL reconstructions, and I talked my daughter into one because she was 25 and a netball player and she wanted to get back to it.
Perfect, thank you very much. I think that's the thing. It's it's a patient by patient basis, isn't it? Looking at the each patient individually, where they're at in terms of how they've recovered from it initially, and then what their longer term ambitions are as well. Do you see sort of what are your sort of experiences, Jimmy, from a physio side?
It definitely comes into what sport they want to get back to. It definitely comes into the age of them as well. So I'm seeing quite a number of, particularly post the ski season, your 40, 50-year-olds who have had a diagnosis perhaps whilst in Val d'Isère of an ACL rupture from a clinic there, and they come to see me with the viewpoint, a 45-year-old saying, do I need an ACL reconstruction? And ultimately, like Mark says, you can get a nice Donjoy armor brace and actually ski very efficiently without an ACL. So it's the question of what they want to get back to ultimately, as to whether I would send them over to Mark and say, yeah, this one's definitely a candidate. But for me, it's more what are they getting back to? Truly, do they want to go through the rehabilitation phase to that level, and what their job is ultimately? They may not be able to have the time to do it.
Yeah, absolutely, and it's a big commitment. Sort of when you go down that surgical route, it's a long time to sort of get back to where you need to be. It's a long return to play, and as you sort of mentioned at the start, the numbers of people that do sort of return to play, is quite a significant number that do drop out and they don't make it back to the level, or at least the level that they competed at previously. So it is a big decision, and I think it's really important that people have all they have the options explained to them. They fully understand what's going to be involved, and nice to hear that you think that muscle stim makes a big difference as well, Mark. Has anybody got any sort of final questions? I know I've got sort of one more that I'd love to sort of hear both of your thoughts on, but I'll throw it out to sort of everybody else first, see if anybody else has got a question.
I can't see any in the chat at the moment, but I guess I'll jump in. So to both really. So what are the biggest changes that you have made in your rehab protocols over the last few years, and where do you see it going with the more recent evidence coming out now?
I think that's a really interesting question. And I think the big difference in the rehabilitation world, I think, has been outcome measures, and has been the improvement in technology. And it's very easy to access a force plate nowadays. It's much easier to effectively get objective and quantifiable data. So, for example, on a force plate, you might be able to start looking at some very detailed bits of information about how well they eccentrically load and what the rate of force development is. So I do think that the technology has definitely changed our focuses in rehab slightly. But also the big thing from me is that we can utilize those as outcome measures, but we have to understand the bigger picture outside of that, which it is a performance measure. And sometimes just going off the performance metric can be deceiving, much like a crossover hop or a triple hop score can be quite positive, and a limb symmetry index being positive, but if their technique to do it is rubbish, then it's a vulnerable position, isn't it? So I think from my perspective, it's a case of the change of technology and the ease of being able to test them to a bit of a deeper level, and then understand that data and apply it into the rehab setting. I think that's really changed probably over the last really 5 or 6 years for me.
Thanks, Sam. I don't know if you were asking me as well. I would go along with what Jimmy has said, but I think the importance of buy-in from the patient into prehab or post-up rehab is so key. That's the biggest change that I think has happened in those of us who work in ACL surgery. We're always going to tinker with the detail of the surgery. We're trying to use the data to make better selections, as I mentioned, rather than just have one operation to do, trying to make it unique to the patient, and also come away from good enough to perfection, to excellence. Now, I guess we're going to struggle because it doesn't have any nerves in it, and Jimmy said that very eloquently earlier about its importance of feedback structure. We're not going to get that. However, if you can get that patient back to feeling as if it's now stable, and the leg strong, and understanding where the leg is in place and time and floor, then they're more likely to get back to their activities that they wish to get back to and be happy, rather than 2 years down the line say, well, I never did get back to my sport, and well, actually, it was a hell of a lot to go through. So, that is where the improvements are taking place. So thank you for all of you out there who are doing work like Jimmy, and I'm sure you are, for helping us, because we can't do it at all without you.
Greg, I'll hand back to you.
No, thank you so much. And I think, I mean, that kind of leads quite nicely into sort of what I was going to ask as sort of my final question, which is, again for sort of both of you, but when we look at return to play for athletes post surgery, I think historically there was so much focus on, you know, that sort of symmetry index between injured and non-injured limb, and that was what everybody cared about, was just whether it was in a certain percentage and then they were ready to go. But there's so much more to it, and you know, you touched on actually an ACL is a brain injury, and we need to address that as well. And I'd love to hear both from sort of Mark's perspective from a surgical side, what you would be looking at kind of before you would deem somebody fit to return, or whether you would leave that decision to the physiotherapist and the clinician that's in them. And then from Jimmy's side, you know, you spoke about how many sort of different things and factors that you're looking at with your patients. I'd love to sort of hear, you know, what are those key things that you're looking at?
Well, I guess I'll have less to say than Jimmy on this, but I think the key factor is working closely with the team. It's very much not my decision. It's not a time-based now. It was always, okay, you've waited 9 months, now you can go back to it. Well, we've learned that that's definitely not the case, and it's got to be based on data. And actually, just comparing it with the other side, well, that was probably why they injured this side in the first place, as the other side wasn't fit for it anyway. So in terms of return to sport, we know that in some of the fortuitous work, mainly by a couple of my colleagues who've treated the elite, more of the elite players, but a collection of our work, that 95% of them get back to their level. But you understand why, because they get therapy and rehab every day, whereas the average outcome is around about 60% might get back to their sports. But we're looking at some groups of people that maybe it's as low as 25% in the under 25s. Some of that group in females, it's even greater than what Jimmy said, that don't get more than 50%, perhaps 75% don't get back to their sporting level. So it's the key measurements and support for that, rather than whatever I do. I'll stop there.
Where do I start? It's having worked in lots of different environments. Mark said it the nail on the head. It has to be a team decision, and we can argue that, okay, we can have a surgically or medically fit knee, but it has no bearing on actually, are they prepared to return to the field, the court? And for me, there's a number of different stages. So classically, for example, there was a, you know, 12 weeks you can run. They may be nowhere near ready to run. We have to look at all the different variables that come into this. So I'm actually, I often explain to a lot of my patients that I actually hold them off running for quite a while, because until we get those neurological things right and that strength right and all those other factors, there's no point. You know, we can jog, great, but I want to run, and I want to run, and I want to build up, and I want to build those running mechanics, and I want to sprint, and then I want to develop into sprinting, twisting and turning. It has to be a gradual exposure. It has to be almost from a controlled position to a chaotic position as you go through your rehabilitation. And as you start to delve back into outside, perhaps, so if we take the example of football, as you start to go back outside, even the simple running drills are so controlled. And as you start to go through cutting and the various degrees of cutting, and then as you build through into the more complex situations of technical drills and opposition and reactions, ultimately all you're changing is the chaotic side and the complexity of what they're trying to achieve. So for me, yes, there's some distinct measures that you need to have. So for example, isokinetic dynamometry, I like them to hit certain scores on hamstrings and quads. I like their ability to jump and land to be efficient through force plates. I like to understand, you know, how well they can control themselves. But as they go back out onto the pitch, it's a measured, it's a gradual progression through that kind of control to chaos continuum. But all of those things have to be done as a team. So if they're in a sports environment and they've got a strength coach and they've got a football coach and they've got all these other people around them, can they assist in that progression through it? And if everybody's on board, then you're going to get a really nice, smooth transition. But ultimately, the final decision is the psychological decision. And if they have an element of fear, if they have an element of a lack of confidence, you can have the best athlete in front of you who can do absolutely everything, but if they are fearful, they are not ready to step back into that competitive environment. So how do we change that? We gradually expose them, and we just put them through the same principles, and we just dip them in, and change the complexity until it gets harder and harder, until the confidence builds. And if you talk to any player who's had an ACL reconstruction a year later after they've returned, so a year they've returned, and then a year after that, they will tell you, I wasn't ready. Most of the time they'll say, I was nowhere near ready, but I thought I was. So there's a big learning process that goes on for the next year or two afterwards as well. So ultimately, take the time. I'm a big proponent of take the year. Use the year as much as you can, particularly even if it's an isolated ACL, take the year if you can. Maybe circumstances why you can't, but ultimately, can you take that year? Can you really build the confidence through the whole process, and ultimately work as a team to ensure that both the patient, the athlete, the staff that sit around that person are happy, and that there's a plan to delve them back into competitive environments.
Just to add, Craig, maybe finally on that, is that there's some evidence that shows that the re-rupture rate decreases by 10% every extra month after 8 months. So you can have a 40% reduction, but if you wait to the year. So we're tending to put patients back, particularly the younger, higher risk group, to the year, whereas we went through a phase of trying to push players back at 9 months or even 6 months. And you're just really risking it. So you might take that risk if they're towards the end of their career and they've got the Champions League final next week, then fair enough, that might be their only chance. And that's a calculated or decision that you have to make with the player in that circumstance.
Absolutely, and no, thank you both. I think it's a really good point. There's a lot to take in and a lot of things to factor in, but it's that team decision, and it's the surgeon, the physiotherapist, the whole medical team that's involved in it, but then also the patient as well. And I think they all have to be involved. Everybody has to have their input before you make that decision. And I think that's the most important thing, and a really nice sort of way to round things off for this evening as well. So yeah, thank you so much for joining us, both of you, and thank you for your questions for everybody and everyone that's joined us this evening.
And just to finish off then, thanks everyone who has joined. We really appreciate it, and we hope you'll agree with us that Jimmy's delivered some fantastic content there, and the clinical discussion there has again raised some great questions, and delighted to have Mark join us, and also Craig's clinical insights. So thanks once again to all who joined us. We will be doing more webinars like this in the future, so keep an eye out, and we look forward to seeing you down the road at some point. But thanks again, have a nice evening, and we'll speak soon. Thank you.